My name is Zoe Clark. I'm Senior Self-Management Programme Officer here at NASS, and I'm delighted to be joined by Rachel Lewis, who's a Rheumatology Specialist Physiotherapist. Hi, Rachel, how are you?
I'm fine, thank you. Hi, everyone.
Thanks for joining us. To begin with, do you want to just introduce yourself a little bit?
Sure. As I say, I'm Rachel Lewis. I'm a clinical lead physio at North Bristol NHS Trust in Bristol, and I also have my own private practice. And I have worked in AS since about 1992, and I set up the service in Bristol. And then I've been doing some research into hypermobility for about the last 8 years or so.
Yeah, so when we met, I thought this is the perfect person I've been looking for because we've been interested in running this topic for a while. So having the expertise in both axial SpA and hypermobility is really, really helpful for us. So thank you.
Hopefully, I can live up to expectation.
Absolutely. So for everyone who's joining us, the session is being recorded. So if you can't join the whole session, please do pop any questions in the comments, and we'll answer as many as we can. You can then come back and catch up on the recording afterwards, either on our Facebook page or on our YouTube channel. And for everyone who's joining the whole session, please do share your experiences in the comments and add any questions, and we'll make sure we cover as many as we can as well. So, Rachel, you're going to do a presentation for us first of all, and then we'll come back for the Q&A, but I'll keep an eye on the questions as they come in as well.
That sounds excellent, and I'm quite happy to answer questions as we go or at the end. If anything's not clear or if it's all a bit too basic, then please shout and I can adapt accordingly. So the
Perfect.
technical bit now to me is actually getting my screen to share with you all properly. I'm better at the treating than I am at in the screen.
It's been
Yeah.
a steep learning curve for me over the last few years. Wonderful. I'll switch my camera and mic off, but I'll jump in if there's anything anyone's asking, that needs answering straight away, if that's all right.
Excellent. So
Thank you.
that's just a little bit obviously about myself. So we're going to be talking about axial spondylitis and hypermobility and how the two sort of combine together in some people. And I was just saying to Zoe, we seem to have had a lot of people recently coming through with this combination. That's warmed me up nicely for this presentation this evening, hopefully as well. So off we go. So I'm not going to go through all of what Axial SpA is, because I think all of you know that from NASS and there's lots of information. So I was going to go through a few basic bits and then a little bit about hypermobility and then a bit about how they combine and how our treatment varies a little bit with both those conditions. So axial spondylitis as the classical features of having back or buttock pain or radiating into the buttock, early morning stiffness. Classically, it eases with movement. So what differentiates it from what we call mechanical back pain, and that quite often it's worse with rest. So usually going on a beach holiday, and that is often one of the things you guys don't like, and pain can often wake you at night. Okay. So if we look at axial SpA as a whole, it often affects mostly the spine, and that can be the whole spine. So right through from your neck down through to your lumbar spine. So all areas of the spine can be affected. Doesn't tend to like the other joints as much. However, it does tend to affect those sometimes a bit more in women. So our hip joints and knee swelling can be symptoms though with AS, and also Achilles inflammation. It's very common, and often the sort of two that join the back pain and the Achilles pain then start to get the inflammatory questions raising for diagnosis. So that Achilles inflammation is what we call an enthesitis, where tendon inserts into the bone. And there's a few other areas around your body, but the Achilles and your adductors in your groin and things are quite common areas for this. You can also get some sternal pain, so pain down your breastbone, where the little bone joints insert into the ribs, go into the breastbone, little joints, just like in the spine, just like in your hip or your knee or your hand, and that as well. So they can also have problems. Very frighteningly, they can mimic a heart attack as well, but they can be quite treatable. And the other one with axial SpA, quite common, is obviously iritis, so inflammation of the eye. And if you get that, our eye specialists are saying, we used to say go down and to see them if it hadn't gone within 2 or 3 days. They're actually saying no, go down straight away to be seen for that as well. And tell them you have axial SpA when you do. And then also associated with that axial SpA is inflammatory bowel disease as well, and then skin psoriasis. So that's a little bit of an overview of the kind of common features, if you like, or not so common iritis and inflammatory bowel, but the associated features as well. So what is hypermobility? Hyper basically means extra, mobility in your joints, so extra movement in your joints. The classic areas that this is considered in are your knees, elbows, thumbs, fingers and spine. So some of you will have seen a thing called a Baton scoring system, which is this guy here. So with each of these, each of your joints score you a point each. So you should be able to bring your little finger up beyond 90 degrees. You'll now see how stiff I am. So it goes to 90 degrees and an extra 10 degrees. Your thumbs, can't do it here, should be in contact with your wrist. You should be able to straighten your knees fully and then add an extra 10 degrees on top of that. And again, you can straighten out your elbow and add an extra 10 degrees on there. And if you bend over to touch your toes, you can get your palms to the floor. So that's where you'll find the difference. With axial SpA, bending over to touch your toes can be one of the most difficult things, but also with hypermobility is one that's very, very easy. And some of you can even put a lot more than your palms to the floor. So to be diagnosed historically with hypermobility, you would have to have scored 5 out of a possible 9 points for those. So each thumb, finger, elbow and knee score a point each, and then a point for being able to touch your toes as well. Okay, so 5 out of 9 would give you diagnosis. However, what that doesn't do is it doesn't include your hips and your shoulders, two of the most commonly affected areas with hypermobility. So it is not the bee's knees of assessment or diagnostic tools. So instead of there being a Baton's criteria, there's a new one called Brighton's criteria. Brighton doesn't just look at the extra movement, it looks at a few other things as well. So it includes the tendons. So we talked about the tendons and the enthesitis in axial SpA as well. Looks at how stretchy your skin is, and also some people can lift those right up, and also how you scar, you can get what we call papyrus scarring. So instead of having a nice neat scar line, it can become quite jaggedy looking. Okay. And how frequently you sublux or dislocate your joints. So your joints come slightly or completely out of their sockets in there. And then it takes into account other things such as prolapses like vaginal prolapse, varicose veins, and things like that as well. Okay. So to be hypermobile, you only need one parent to give you hypermobility because it's a genetically dominant gene. It affects about 0.6 of the population. And as it causes these subluxations or dislocations where the joints slightly come out of their sockets because of sometimes a bony structure. So with a hip, you normally have a big solid piece of bone here and then the ball of the hip here. And sometimes with that, they are more shallow, so it allows your hip to have loads and loads more movement. The shoulder relies much more on your rotator cuff muscles to support the shoulder and joint rather than the bony structure as well. So that's where we rely much more on the muscle control holding the joint in place. So today I had a lady who had very, very tight pectoral muscles here, were literally pulling her joints out in front because she had no muscles at the back, pulling them back into their right place. Okay. And then proprioception. So proprioception is how you know where you are in space. So that's where sometimes as children, it used to be called clumsy or sometimes ataxic because you tend to bump into things and then bruise quite often. And with hypermobility, you can often bruise more easily as well. Okay, so what happens in hypermobility is that you get more information in the middle of the movement here. So if my full movement goes out straight, in hypermobility, I get lots of information in the middle here telling me where I am. Whereas if normally I would get information at the end of the movement from both the joint and the muscle receptors telling me you've got to the end of the movement, put your brakes on, and the bony structure would actually physically stop me. So with hypermobility, there's a combination of those things don't get that information telling you to stop at the end of the movement. The ligaments and that are a little bit more lax, and then the bony structure allows you to actually move further, which then that all makes sense there. So the treatment, if we look at the medical treatments here, if we look on one side, we've got the Axial SpA side. So we've got the medications of non-steroidal anti-inflammatory drugs, or NSAIDs. And then we have our biologic medications, and then our general analgesia on that as well. So there are a few others we can put in there, like depamedrone injections of steroids and different things like that, but being the baseline things there. If we look at hypermobility, we really don't have that medical barrage to throw at it, because there's some of you, if you are trying to be anaesthetized for surgery or something, some of you anesthetics have no effect at all. And so if you do have hypermobility, do make sure if you go for surgery that they are aware of that, so they can give you the right medications to knock you out. Okay. I say hypermobility is not an inflammatory process, so the non-steroidal anti-inflammatory drugs often really don't do anything for you at all, because there isn't that inflammation for them to work on unless you sort of injure something. So a common one is you walk around, you trip over and you sprain your ankle. So it would help with the ankle sprain, but then it wouldn't help long term with things. And again, analgesia, such as things like paracetamol, cocodamol, caproxenol, all those kind of things, often don't have much benefit either. Okay, so that leaves us then with all the non-pharmaceutical, the non-druggy kind of things that we can use. So here, if we compare the two with the Axial SpA in blue and the hypermobility in the plain, if you like, exercise is there in both of them. Hydrotherapy can be really good for both of them. Your posture is really important. So if you are going to fuse with AS, we want you up in a good upright position. However, with biologics, we don't see those kind of problems like we've used to. And posture is really key into keeping your joints in the right place with hypermobility. Hot and cold treatments such as hot water bottles, wheat bags, ice packs, cold gels, etc. And TENS, a transcutaneous electrical nerve stimulator. Now, TENS can be a really good way of easing pain. However, it's like Marmite, it's either excellent or useless for you, but you don't know until you try it. You don't want to try it if you have atrial fibrillation or a pacemaker, because it will repace it for you. But if not, it's a really, really nice way of treating pain without using medications. And it basically, in very simple terms, blocks the pain message going up to your brain. So instead of getting a pain sensation, you get a tingling kind of sensation. So you'll see that hot, cold TENS features on both sides of the equation here. Now, pacing and the 4 Ps, which are planning, prioritizing, positioning, and posture, is important in AS. However, that's in bold because it's even more important with hypermobility, because there's sometimes the amount of fatigue you can use and how you use your muscles is what's really, really important. So our aims in Axial SpA are to get you to have joint lubrication, to enable you to gain movement and to stop you getting stiff and keeping mobile and that. However, with hypermobility, it's all about stabilizing and protecting the joints to keep them in place. So in some ways, you've got the two extremes of conditions. You've got the one condition that can make you really, really stiff and one that makes you extra mobile. However, the actual aims of treatment are slightly different there with them. Now, with Axial SpA, what we really need is movement. You need the joints to be put through their movement. So it's like you've lubricated them or re-oiled them. So you've literally just sprayed WD-40 all over them. And that's what your exercise is really, really important for. And doing that exercise first thing in the morning to ease off muscle stiffness, and that is really key for that as well. However, we need to target the areas that are affected. So we need to work really on your spine and your hips and your posture and things like that. However, with hypermobility, it isn't a case of just moving and just re-oiling. It's all about the quality of how you move and which muscles you're using, which is much, much more important than some of our other conditions, and say like Axial SpA. Okay, so that is the key difference for them. So Axial SpA, I would say it's all about the quality of movement, using the right muscles at the right time. So we have that balance of muscles working together. So say, like my lady this morning, you're not having your joints pulled in one direction and literally causing them to sublux. So one of the common ones, again, is when you're in a lot of pain, you tend to lift your shoulders up here. Now that can give you nice headaches, and it can restrict your shoulder movement and things like that for you as well. And it's really important to calm those down. Now with AS, you'll get that to a degree, and you'll also have that with some inflammation in your neck and things that can do it. However, that's one that can really start to trigger off problems. And what happens is these muscles are constantly working. They're never having time to switch off and rest. So the only way that these muscles can tell you they're basically working overtime is to give you pain, to tell you to do something about it. And they tend to do that a lot more with the hypermobility than with the AS. It's a different, slightly different kind of mechanism with it. Okay. And I say we want to strengthen the muscles to protect the joints, and then we need to stretch out tight muscles. So in AS, we know that you can get tightness in your adductors, the muscles on the inside of your groin, your hamstrings, these pectoral muscles and things, they all need to be stretched out. However, we don't want to overstretch them so that we cause them to sublux and that, but we need to then have them balancing out with their opposing muscles on the other side to keep everything in a good position. Okay. And again, with Axial SpA, if you overdo it, you'll just get a bit too achy, and the pain will tell you to ease off a little bit, or the muscle aches will tell you to ease off a little bit. If you over exercise with hypermobility, what that will tend to do is mean that the muscles too tired to keep on taking the strain, and therefore the joints take the strain, which means they would then be more likely to sublux and give you pain, more so than they would be by over exercising with Axial SpA. And then we also need to look at working your heart and lungs to stop you having heart attack, stroke, diabetes, all of those things as well. Okay, hope we're all okay there. So our treatment. This is where things can vary a little bit. So if you have Axial SpA, we would normally do a metrology system. So your local physio department should be measuring your height, your ear, that tragus thing, that flappy bit in your ear towards the wall for your posture. What we call your modified shoulders, where we put a couple of marks on your back and then we measure how far you can bend forward. So that tells us more of what our spine is up to, how far you can bend down to the side, and how far your neck rotates. However, I'm talking to one of my patients who's moved recently. Unfortunately, that's not available everywhere, but that will be our standard way of measuring and seeing how much your movement you have. And it's a really good way of seeing if you're improving or if you're quietly stiffening up and losing that movement without realizing it. And that's one of the things that metrology is really good at, picking up that slow creeping stiffness where you're losing movement. And then we need to target our treatment to increase those movement in those areas. However, if you have Axial SpA and hypermobility, your metrology will be off the scale. You will have much, much more than normal than for everybody else. So what you'll find is that with some therapists, they will just say, oh, you're absolutely fine, don't worry about it. But actually what we need to know is what that was like compared to your baseline measurements when we first measured you, because it might be very much different to when you were first measured. Okay, over the years. So it's having that regular monitoring and seeing how things are changing and then directing our treatment according to that. And that again will come with therapist knowledge and awareness, and to be honest, our own patient mileage. So me being old, I've seen this quite a few times, and we know that you will increase that metrology for us, just like some of our martial arts expert will do the same. So it's what's different for you, not what's different to the normal metrology that we see, that's key with this. If you go to do various exercises, it's really important more so with this combination that the therapists or fitness instructors, wherever you're going, they should be correcting you and making sure things like your shoulder blades and the low bit of your lumbar spine is working. So if you think of an angry cat exercise, so angry cats, where you're on all fours and you're arching and hollowing, okay, and that really nice movement. You can cheat very easily at it, and you can get all the movement from your middle back or your thoracic spine, and your low back can go on holiday. So that's a key example of where we need to make sure the right bits are moving at the right time, and we have this quality of movement where all the muscles are in balance and things like that. So if you're going to an exercise class and they're not correcting you, walk out and go somewhere else that does. Okay. Then in your back, we have these what we call syndesmophytes, these extra bits of bone with axial SpA. And you can also have what we call a spondylolisthesis in hypermobility, where the spine can very slightly start to slip on itself. Okay, so you have this balance of having mobility and stability required. And those are different movements. So the syndesmophytes prevent you moving into flexion. The spondylolisthesis makes you get more pain and extension. So flexion being when you're bending forwards, extension when you're coming backwards. So again, these are kind of things that your therapist should be aware of, and are the key things telling us which conditions causing the problems. With hypermobility, again, if you injure yourself, sometimes you can be a little bit slower to recover, and this is where your pacing can be really, really important. So what often happens is that if you have hypermobility, you can injure one area, and then the physios will often work on, say, your ankle, and then they don't worry about the rest of you. And so what happens is your ankle gets really, really good. But as you have that extra flexibility, you just knock the problem onto somewhere else. So it goes to your knee or your hip, and then it goes to your spine and things like that. So this is why we need to really make sure we look after all of you holistically, not just one body part at a time. So quite a lot of outpatient physios will just look at the foot, whereas a rheumatology physio will look at all of you and balance everything out. And that's really important. That's where, say, making sure that if you're hypermobile, you have these compensations where you have all these extra movements and you can adapt and accordingly, which is really, really good short term to get you by. Long term, it will start to knock this pain around your body a lot more. So it's making sure everything's right, working in the right sequence at the right time. The other things we need to think about for both sides of the equation, especially for women, is bone protection, because with Axpa, you load your bones slightly differently. And then also, if you're not mobile because of pain, you're not loading and stimulating your bone enough for when you hit 70 and 80. I say posture is really key, and that's a whole session on itself we can go through as well. And ergonomics, how you interact with your environment, be it chopping things in the kitchen, in the bathroom, at your office, your laptop, all of those things, gardening, crafts, everything you do, how you interact, having everything at the right levels and that for you. I say looking at both the spine and all the other joints affected as well. That's really important, not just blinking it's just in your low back or it's just in your neck. It's all of you we need to look after. And again, with Axial SpA, we need to get you on the moving, and little and often is really good for both conditions. However, with hypermobility, it's very much more about the quality of the repetitions and getting that control. So in the mornings, you just want to get yourself on the move, re-oil yourself and free everything up. Then later on through the day, you want to really look at how you're moving and the quality of it, using the right muscles at the right time, so then you don't start to cause more problems further down the line for yourself as well. Okay. Then this is a bit of to the end. There's a lot of research coming out into hypermobility at the moment. When we were doing online courses during COVID, we had 10 people on our hypermobility course. And one lady said to one of the others, does anybody else have an autistic child? 6 out of 10 people said they did. And it's now becoming quite evident that ADHD, autism and dyslexia and things like that are very, very much related to hypermobility. And so there is now going to be a whole glut of research coming out in that area. So there's a few bits emerging at the moment, but if you watch this space, you'll probably find a lot more things happening over the next few years with a lot more information coming out on that for you. These are very good sources of information. So the Hypermobility Association, hmsa.org, the Ehlers Danlos Association versus arthritis, and it goes without saying, obviously NASS. So I've used obviously nice NASS colours there for you as well. But however, you will often read lots and lots of information. Remember, what you read on the internet isn't always of the best quality. So if you're unsure, please do ask someone to qualify that for you a little bit more. And you tend to see that a lot more with hypermobility than you do AS, because often people with hypermobility get a lot less information than people with AS. It's more recognised in that as well. And we're there. So any questions or anything there as we go? I'll stop sharing, and then I hope that was useful. Bit of a whistle-stop tour in the time frames, but I'm more than happy to answer any questions or do another session another time.
That was fantastic. Thank you so much. It was a really great overview of everything. And yeah, you covered a lot in a short amount of time. So that was great. And as I suspected, we've got a lot of questions coming in as well. So I think we'll probably have about, if you're happy, so 10, 15 minutes of questions.
Yeah,
And
I'm
then
happy to do whatever it takes, no problem. I say if we need to do it in 2
lovely.
batches for everyone, we can do it again.
Lovely. We'll cover as many as we can and then we'll go from there. Perfect. So just thinking some more sort of general questions to begin with. Catherine asked if hypermobility is more common in women.
Yes, it's something like 5% and 0.6%, I think, are the features. So yes, it's often probably more recognised in women than men as well. However, you only need to look at Britain's Got Talent to see what you can actually achieve with hypermobility as well.
Absolutely. And Chantel asked if you know whether there's a higher prevalence of hypermobility in people with axial SpA, because these same things seem sort of linked for a lot of people.
No, I would say it's quite a low prevalence with that.
Okay.
So that I just happen to have an interest in both camps, if you like. So I see a lot of people with AS and a lot of people with hypermobility. The actual number that have both together is quite small.
Mm. I mean, from the comments that are coming in, it's been really good to actually get those people together to be able to share their experiences. Because I think, yeah, a lot of time, you well, with charities and things, organizations, we focus on one condition or the other. So it's great to have combined them this evening. Brilliant. So a few other questions which are maybe a little bit more clinical. So I'm not sure how much advice you can give
Sure.
without knowing the person. But Suki, before the session, asked both about running and how she can sort of run comfortably without tendon issues. And she finds things like gardening. She gets a lot of hand pain when she's doing those kind of fine movements. So I don't know if there's any advice you can give.
So gardening is probably looking at the brand of like I can't think the secateurs kind of things that you use in the gardens and things like that. So they're some are easier to grip than others and things like that with them. And you can obviously get long handled tools as well, so you don't have to bend down as frequently. And again, gardening is the classic one. You go out to do something, and then you think, oh, I just do that bit, I just do that, and I just do that, and you think, oh, I'll go and get a cup of coffee, and then half an hour later on the way to the cup of coffee, you're now starting to get pain. So it's one of those classic things of needing to pace yourself. So actually say, I'm going to do half an hour, and then I'm going to stop, and then actually stop. So set a timer on your mobile phone, stop, go and get your cup of coffee, and then come back out and change position. So do a bit of standing up pruning, then bend down, do a bit of weeding, bit of potting at different levels. So you're in different postures all of the time, both for AS and for hypermobility. And then what was the other question? Running, wasn't it?
Yeah.
So running is a bit variable. If you ask me, I hate running with a passion. I would always hit the pool. So it's finding, again, any exercise that you enjoy doing yourself and something that you will stick to is what's really important. It's doing something is better than doing nothing. Okay. However, running is really good because it puts impact through your joints and your bones. So it's really good for bone density and things like that. So again, very good for our female population because osteoporosis affects 1 in 2 women, 1 in 5 men over 50. However, when your joints are painful, then that can't often be the best thing for you. So having really good shock absorbing footwear on your feet can be really useful. And you can also go, a lot of the shoe shops have like a biomechanical assessment area, and you can buy shoes that are there for people that pronate, so people's feet that turn down and in, or people that have high arch feet and are supinated. So they often review your gait or your running pattern, and then they can see which shoes fit you best. So if you like to run a lot, it's worth investing in that kind of thing to support you, and then know what to buy to help you there. Then you need to think about what terrains you're running on. So is it on hard ground, on sand, on the grass, and things like that? So again, a lot of road running can make your joints have more problems. So a bit of a combination, and again, how far you run for, and make sure that you have a couple of rest days a week as well.
That's fantastic. Thank you so much. And actually, this kind of links in with the exercise sort of theme as well. Victoria was asking about how to get the right balance between exercising enough, but not then triggering a flare up. It's probably $1 million question, isn't it?
I was about to say, yeah, that is. And that's where, again, is very, very individual. It's not something that one size fits all. So that is, pacing is working out what you can do on a good day and then going at half that level. Because otherwise what happens with pacing is that you do loads and loads and loads and loads of activity, and then you think, oh my God, I feel really awful. So then you take 2 or 3 days to recuperate. So you do no activity. Then you think, oh, I feel quite good now. And then you go and do loads and loads and loads again. And then you have another couple of days to recuperate. So you're living life up and down on a roller coaster all of the time. So the idea is, from pain management programs and things, is that you start off at about half of what you could do. And then you gradually build that back up over time. So instead of going up and down on your roller coaster, you're just going up and down on a much, much more even keel and doing things. So I think pain is usually one of the biggest indicators. However, if you haven't exercised for a while, expect to be a bit achy, because you'll be moving things that haven't moved in ages and using muscles that haven't been used. So again, start off really low and then gradually build up. So swimming is a good one, because sometimes when you get in the pool, it's really good for your heart and lungs. It takes your body weight and things, and it's often you can achieve a lot in there. However, you get in the water, think, this feels great. And then if you stay in there too long, you nearly crawl out because you're worn out and you don't realize how much you've done until you get out. So if you've not done anything like that for a while, again, start at about 20 minutes. Say, right, I will get out after 20 minutes. You probably won't want to, because you will feel good, but get out. And then the next time, again, do a little bit more and a little bit more and a little bit more. It's a sort of making time to save time, and that the tortoise and the hare, and you get there. And actually over time, you actually achieve a lot more than if you go on your yo-yo up and down all of the time. So muscly aches are acceptable. Nasty sharp pains are probably telling you not to stop, to ease off a little bit, and to say pacing yourself so you're gradually building up. Government guidelines are about 150 minutes of exercise per week. So you're looking at about 30 minutes a day, 3 days a week, probably cardiovascular, and 2 days of strength and balance training as well. Okay.
That's brilliant. Thank you. And I think it's really, really good way you've described pacing as well, that actually long term you'll be able to do more, because it's one of the most frustrating things to do, I think. So as someone living with both the conditions is, yeah, you just want to get on with it and get on with things and life. But long term, doing the pacing does actually enable you to do more. So it's, yeah, it was a really good description.
It's the hardest thing as well, because you want to go out and do things and you want to live life, and some things like looking after kids and that, you can't really pace that easily, and it's trying to work out how it all fits in with your life. So again, sometimes rather than thinking, right, I must exercise, and going to work, coming home and then starting to do an hour's exercise can be really, really hard work. So trying to do a little bit during the day, so things like bringing your shoulder blades back and down, and that, and correcting yourself there, going down to the sides, doing a push-up on the wall, any of those kind of things you can do during your day, and bringing it every time you go to the kettle, lift your legs out to the side and out backwards. So you've done stuff through the day rather than having to start at the end of the day. And then I have to plug it. I do a lot with NASS. Well, I help set NASS Online up. So if you are struggling on your own, we have a whole team of us on NASS Online, something going on every day of the week. And we all do something slightly different. And we've got Tai Chi and yoga and Pilates, as well as physio stuff. So you're more than welcome to join us there. If we recognise you as new, then we will be guiding you through and asking you as you go as well.
And in the comments, I'll put a link to the online branch details as well, so everyone can get in contact if they're interested in joining. But I've joined the chair dance and it's really great fun. Brilliant. So I think we've got just a few more questions. So we had a question before the live actually from Abby. who'd been told that she's likely to get arthritis in the joints that she's hypermobile in, particularly knees, hands, and elbows. Do you know is it inevitable, or what's the
No,
research say?
everyone used to think if you had hypermobility, you were much more at risk of getting osteoarthritis, so degenerative sort of wear and tear in your joints, which is those areas you've just described, often the weight-bearing joints, the hips and the knees, and then the hands. However, that's now been disputed. So you would probably be as likely as the rest of the population, maybe a slightly bit more, but there's no definitive you will get worse because you have hypermobility. It kind of strikes you just as much as it would strike the rest of the population. It kind of picks who it wants.
That's reassuring in a way. It's certainly not inevitable, at least. That's good. Lovely. And the last few questions I've got. So Jacqueline asked about dealing with sacroiliitis, and if you have any tips on if you can differentiate the sacroiliac pain, whether it's the axial SpA causing it or the hypermobility, or is that a tricky one again?
That would be a brilliant, could even be a combination of the two. It doesn't have to necessarily be one of them that's causing the problem. If it was more axial SpA, would be much more what we call an inflammatory pattern. So those pointers we put at the beginning where you have early morning stiffness. However, hypermobile people complain of early morning stiffness, but you won't have it documented anywhere as a causing factor. But it also is one that will ease with exercise and things like that. And it will respond to anti-inflammatories more so as well.
Oh, that's really helpful. Thank you. And Nicola was looking at, so if you have any advice on advocating for herself in rheumatology appointments when they're assessing her axial SpA because she has the hypermobility, sort of, like how you mentioned in the metrology and things, that it will mask it a little bit. Do you have any advice
Yeah,
on that?
I think the main thing is just to remind them that when you do go for your metrology, is that remind them what was it like before. Has it got better or has it got worse? And maybe just give a bit of an off the cuff kind of comment that, oh, because I'm hypermobile, my measures are always really high, but what does that mean to me? And just make them think about it a little bit. Because especially if you've got a more junior physio, they're not going to recognise it. I'm sorry, but we do try and educate them all, but they aren't going to recognise it. And the same with our martial arts people. They get really high hip measurements and that. But again, if you just go, oh, that's absolutely fine. But when you look at what people have had before, it's what's fine for you, or not what's fine for the normal metrology system, if you like.
That's really helpful. Thank you. And just a couple more questions. We had a question from someone who has tried a few different biologics and hasn't found them helpful. They have both AS and hypermobility, and they didn't know whether it was maybe the hypermobility that was impacting it. Do you have any advice? Obviously, we'd say speak to the rheumatology
That's
team.
a hard one to tell without knowing all the other data that goes along with biologics and things like that. But normally biologics are very, very effective in axial SpA. However, sometimes it does take a couple or so to find the right biologic for you. I think when biologics first came out, they were seen as being the be all and end all, and they would kind of cure everybody. But we know that's not always the case, and that now we have many, many more available to us. That makes life a lot easier. But if it's more sort of muscular pain, and that I would say it's probably most likely to be the hypermobility.
Oh, that's great. Thank
And it's
you.
looking about, say, how you move rather than just moving.
Wonderful. And then finally, we had a question. Mandy and Claire both asked, who diagnoses hypermobility?
That
Again,
little hot potato.
yeah.
So we, as physiotherapists, we can easily diagnose hypermobility. However, again, some physios don't know what they're seeing either. We do a lot of education sessions trying to advise people around the country. And we've actually done a whole questionnaire looking at what physio treatments are available around the country and how people diagnose it and everything. We have done a study on that. And again, we're very much that we treat all of you and we look after all the joints in one go. Otherwise, we get this knock-on effect, whereas other people were very much that they would only look after one bit of you. And we also very firmly sit on the side of the fence that you're going to use all of your hypermobile movement, whether we train you to or not. So we're better off training you to use all of your movement. Some other physios will say you must not move into your hypermobile movement because you will damage yourself. There is no evidence whatsoever to support that. Okay, so you need to have control of all of your movement. I've got a lady who is just hypermobile, and she was brought in the paediatric service and told never to move into a hypermobile movement. She'll damage herself. She had a little boy herself when she was about 19. And I said to her, what are you going to do when your little boy runs off? She goes, well, I've got to go and get him, haven't I? And I said, that's exactly why you need control of all of your movement. So we very firmly sit on that side of the fence. And that, but you will meet very different opinions when you go to different physiotherapists. So I'm sorry about that, guys. But that's where my department and our belief is, from the work that we've done and from the research that we've done.
That's really helpful, and it's good to hear that from you as well, because then that helps people when they are advocating for themselves in appointments as well. Absolutely. And I have linked a couple of EDS charities, Ehlers Danlos charities, in the comments as well. So if anyone's concerned about anything like that, then you can always go and have a look at their information as well on so the other signs of the other conditions that sometimes rheumatologists would be the ones to diagnose as well.
Yeah, that's what I was going to say. I went off tangent then, didn't I? So yeah, diagnostically, we would diagnose hypermobility quite easily. We wouldn't diagnose Ehlers-Danlos syndrome. So some people with Ehlers-Danlos can have like valve problems in their heart and that. So we would send you for echo, but those kind of things the consultants would review for you. So more often than not, it would be a rheumatologist, occasionally an orthopod, but more often a rheumatologist would diagnose alongside ourselves. We would diagnose the hypermobility, but not the other side of any of the other queries in Ehlers-Danlos.
Oh, that's really useful to know. Thank you. So I think we've actually covered all the questions that have come in. So if anyone has any last minute questions, please do pop them in there. And I've seen we have got a comment from Joanna, whose daughter has just been diagnosed with AS and hypermobility, and it's feeling quite overwhelming and confusing. I don't know, Rachel, if you've got any sort of words of wisdom, but also if anyone wants to reply in the comments, sort of who has both conditions, then perhaps sort of reassure Joanna as well. That would be nice too.
Yeah, I probably said most of the things there, but we run both an ankylosing spondylitis. Sorry, I've been around too long. I still call it ankylosing spondylitis rather than axial SpA. I have to think axial SpA in my head. But we run a group for education and treatment of axial SpA, and we also run a separate one for hypermobility. And what we find in that is very much you learn from talking to each other. So with axial SpA, it's really good to get different ideas and things like that. With hypermobility, we find that in some ways can even be a little bit more important, because you've got so much extra movement. People always say you're normal, or you always think you're a little bit different to the rest of the population, and that when you meet other people with it, you realize that actually you're quite normal within that as well. And that's really quite reassuring in itself. So that's where I say being able to have things like NASS is really, really important to help each other out. And sadly, I went to a patient's funeral from one of our NASS guys recently. He'd been with us since 1999. It tells you partly how long I've been around. And so when we went to the funeral, somebody said, oh, I went and mended his curtain last week. Another person said, oh, I took him out to watch the birds the other week. And everyone was involved in helping this guy because he lived on his own and everything. That was just so nice to hear how NASS had developed all of this. It's not just, as physios maybe see much more as just an exercise group. It's not. There's so much more to it. And that's where now with online and all the other local groups, there's so much NASS can offer, and it is a lot more than just exercise. And that was really, really highlighted at this funeral. It was so nice to see that. It was really reassuring.
Oh, it's lovely to hear that sense of community and the friendliness around it as well. Thank you. That's wonderful. So yeah, we've covered all the questions. We've not had any last minute ones come in, but if anybody's watching this on catch up, please do feel free to add any questions that we haven't covered. And Rachel, if you're happy, I can always send those over to you and I can answer them in the comments. Lovely, thank you. So I don't know if there was any sort of final thoughts from you, Rachel, before we finish up.
No, the main thing is stick with it, guys. Some of these things do take time. But as you stick with it, it does improve. And also sometimes you feel you're not always getting better, but what you aren't doing is letting yourself get worse. So kind of stick with the program, keep at it. And if you are struggling, then do ask for more help. And there are a lot of us out there to help you and support you.
Thank you. That's a lovely note to end on. So before we finish up, I'll just let everyone know the next session is going to be on Thursday, the 14th of December at 6 p.m. And I'll be joined by physio Emily Clark, who's going to be talking about swimming with Axial SpA, which is perfect because we've mentioned a couple of times in this live how important and helpful that is. So it's good timing.
And Emily does a Monday online group as well.
She does, yeah. We've got a NASS online theme. Wonderful. So thank you so much, Rachel. That's been a fantastic session, just absolutely information packed. And yeah, been really wonderful to answer everyone's questions as well. So thank you.
No problem. I hope it's been helpful for you all. And obviously, any queries, don't hesitate to contact.
Perfect. Thank you. And thanks everyone for getting involved in the comments. Lovely to see so many of you. And hopefully see you all in a couple of weeks for our final session of the year. So thanks again, Rachel. And yeah, I'll speak to you next time.
Thank you. Hope to see you online.
Yes.